Good afternoon and welcome. Thank you all for being here today for our first Arizona Community Grand Rounds session of the new year. We're excited to kick off our 2025 sessions with our expert speaker today. Couldn't be more thrilled with the session topic and our speaker. I'm Carla Berg with Blue Cross Blue Shield of Arizona, and I'm so excited to dive into the topic today at hand, which we have around neurology and MS. Before I introduce our speaker, I'd like to extend a thank you to our partner, the NARBA Institute, for being a critical role in making the Arizona Community Grand Rounds happen. And thank you to Mary Jo Gregory, Dr. Mark Carroll, Jessica Rigler, and Jennifer Pierce for the work to bring today's session together. Now, with that, it's my great pleasure to introduce to you and, in a brief summary, summarize Dr. Hendin's extensive bio. I would like to welcome Dr. Barry Hendin. Dr. Hendin is a board-certified neurologist with over 45 years of experience and a special clinical interest in multiple sclerosis. An Air Force veteran, Dr. Hendin's extensive career includes working as Chief of Neurology at Wright-Patterson Air Force Base and as Chief of Neurology for 35 years for Good Samaritan Hospital, as well as serving as Director of the Multiple Sclerosis Clinic at Banner University Medical Center from 2015 to 2020. He joined the Center for Neurology and Spine in 2020 as one of the core group of neurologists dedicated to the comprehensive and multidisciplinary MS Center of Arizona and the Center for Neurology and Spine. Originally from Missouri, Dr. Hendin received his medical degree from Washington University Medical School, interned at St. Louis Jewish Hospital, and completed his residency and fellowship at Barnes Hospital in Missouri. He then relocated to Arizona and has been here since the mid-1970s. So welcome, Dr. Hendin. I'll just skip to the next slide with a brief disclosure and CE information. So just according to our disclosure, all planners and speakers, presenters have no relevant financial relationship to disclose. The Arizona Alliance for Community Health Centers is accredited by the Arizona Medical Association to provide continuing medical education for physicians. And the session today has been approved for 1 credit as listed here. We will have more information at the end of today's session around those CEs. During today's session, there'll be time to accommodate for Q&A, so please use the Q&A function to submit questions, and as time allows, we will get to that at the end of after the presentation. So without further ado, Dr. Hendin, welcome, and I will hand it over to you.
Thank you very much, Carla. I had talked to Carla before we began this discussion and said I think I would like to change the title to basically MS, where we've been, where we are now, and where we're going, because that's really the way I'd like to approach this discussion. And in the end, to remind you all the important role that you all play in primary care of people with MS, and as well as the role that we think we play as the specialists in the care of managing people with MS. But there'll be a discussion of where we're going, and that is latest research, but also just how to take care of MS people, how to take care of people with MS. And you'll see above it says MSAA, that's the MS Association of America, one of the 3 not-for-profits in MS, and I'm their chief medical officer. So that's at least a designation that I am fond of. Next. And this is just the disclosures, but none that will be related to the discussion today. Next. I've been introduced, and so we come to understanding MS. Next. And next. So I'm not so sure I'd have you read this slide in detail, but rather in words me try to say what I think MS is. When I was still a medical student, the discussion of what is MS, it's a disease that is autoimmune, or at least immune mediated, attacking the central nervous system. That means the brain, the spinal cord, the optic nerve, and it does so in various ways. But the relapsing form of MS was one in which we made diagnoses regarding attacks that were disseminated in time and space, that were separated from each other in time and in different parts of the nervous system. And that made multiple sclerosis, multiple scars by its origins of name. What the next line says is that everybody's different. And I think that is intuitively correct. Everybody knows that. Some people have very obvious manifestations of their MS because of gait and motor dysfunction. Others not so visibly. They may have more depression as part of MS. They may have more cognitive dysfunction, mild, part of MS. But some of those are things you can't see. So there's both visible and invisible manifestations of MS. Next. So this is the part that if we were talking to patients would be the why me? Why do I have it? I've done everything right. Why do I have MS? And so the explanation is not very different. When I was a medical student, and again, I've been a neurologist in the Valley for 50 years. When I was a medical student and early, we would have said there's a genetic predisposition and there is a trigger, because genetic predisposition isn't autosomal dominant, autosomal recessive, sex-linked, etc. It's a factor of multiple genes, probably more than 50, that creates susceptibility to autoimmunity or create resistance to autoimmunity. If you have lots of susceptibility genes and fewer resistance genes, you're more susceptible. If you have more resistance genes and very few susceptibility genes, you're less likely to have MS. In the general population, the likelihood of MS is 1 in 1,000 in America. So all across the board, it's a 1 in 1,000. If your mother or father has MS, it's 2 in 100. So now it's gone up 20 times, but still not the level of a autosomal dominant, autosomal recessive. The way that I try to point out the susceptibility genetically is to say, if a patient has MS and her identical twin sister asked how likely it was that she would get MS, if this was a purely genetically driven disease, then it would be 100%. One sister has it, the other sister with identical genes, she'll have it too. Here, the actual number is 20 to 30%. So if one sister has it, it's 20 to 30% likely that her sister identical twin sister will have it, which means that there have to be other environmental factors that allows one person to have MS and prevents the other person from having MS. So what are those triggers? We think that vitamin D deficiency and sunlight, lack of sunlight, increase susceptibility. We think cigarette smoking creates increased susceptibility and worsens the course of MS once you have MS if you don't stop smoking. We are really in recent years emphasizing the role of Epstein-Barr. We've always thought it might play a role. Now that role is really solidified. There was a US Armed Forces study that showed essentially that although most Americans have had contact with Epstein-Barr, that in MS, it's virtually 100%. So it goes from being highly predominant in the general population to 100% in MS. And that became statistically significant in a very large study. So what we now say is it looks like Epstein-Barr is obligatory for the cause or the triggering of MS, but insufficient. Since everybody else has EB virus too, and they don't get MS, it's not sufficient. But for people who do have MS, it is an obligatory virus, and especially if they had mono, and especially if they got their EB virus exposure in their teens. So that's a better understanding today. That means that we may be wanting to do some things in the future addressing the EB virus. Next. So I think that all of you, I assume, certainly I, was taught to think of MS via the categories. 20, 30 years ago, it was the discussion of relapsing MS with sometimes secondary progression. versus primary progressive MS. So relapsing MS in its various forms, 85%, primary progressive MS, 15%. The way that I try to explain to medical students or interns or residents the difference is relapsing MS usually has a date of onset. The patient will say, on Wednesday, January 9th, I had the sudden onset of loss of vision in my right eye, optic neuritis, or sudden numbness and weakness in my lower extremities, partial transverse myelitis. They'll give you a date specific. That's the attack that characterizes relapsing MS. Late in MS, there's more progression. And we tell people MS is always inflammatory from before you ever knew it to the last states. And MS is always progressive. But in the early phase of MS, it's the attacks and inflammation that's the most obvious. In the late part of MS, it's the progression, the degenerative aspects of MS that are the most prominent. And we've done a very good job of treating the relapses, but still feel that the progressive aspects of MS are an unmet need. Primary progressive MS is very different. That's when a patient will say, I can't tell you when it started. I used to be a runner, and then my times kept getting worse. My legs started feeling heavy. I became a little more urgent and frequent. Then I took a couple falls, but they can't give you a date. And then you say, how long has it been? It's been a year or 2 or 3, a month or 3 or 5, but without a specific date. That's insidious. Then you'll see above that on the left side of the slide deck, some other terms that become relevant. When I was a new neurologist, the requirement was dissemination time and space. You needed 2 attacks in order to be called MS. But the question was, if you have, that was great for a time when there were no disease-modifying therapies. When disease-modifying therapies became available, the question was, couldn't we diagnose earlier so that we could treat earlier if indeed early treatment made a difference? And it does. So there the question was, what would happen if you only had a single event? CIS, or clinically isolated syndrome. CIS with the appropriate MRI is really early MS, and we will treat. Then the question, pushing it back a little further, was RIS. What if you were in a motor vehicle accident or saw your physician for headaches, and they looked at your MRI and they said, we don't know what's going on, but your picture looks exactly like MS. And the patient says, but I have nothing that ever has occurred to me that would signify MS. I've never had optic neuritis. I've never had imbalance. I've never had double vision. I've never had weakness, numbness. I'm perfect. And that's a radiologically isolated syndrome. As we keep pushing the diagnoses further and further, earlier and earlier, we're now including RIS with certain radiologic characteristics as of early MS. And so be aware that the evolution, the where we're going, is to earlier and earlier diagnosis. We diagnose them as via what's called the McDonald's criteria or revised McDonald's criteria. In October, the new revision was proposed, and so the 2024-2025 revised McDonald criteria push the definition of MS not just to relapsing MS and progressive MS, but CIS and RIS, earlier and earlier. Again, why? Because the earlier we treat, the better the outcomes for patients with MS, as long as we get it right. The other evolution, so that's one thing I want you to know in terms of where it's going. The other where it's going is the newer model of thinking about MS, more and more discussions of the biology of MS, not always talking about the phenotype, relapsing, progressive, et cetera, but what's going on? What's going on the cellular level? And here we talk about the acute inflammatory events, relapse-associated worsening. That's the predominant aspect of early relapsing MS. And PIRA, that's when people start having progression independent of relapse activity. Keep your eye on PIRA. It's been the unmet need, and there are unapproved agents which have been successful in trial that have had successful outcomes now in treating PIRA, progressive MS without relapses. It's a very exciting change. just a few months old in terms of the successful trial. Basically, end of last year. Next. So evolution of diagnosis. 50 years of progress. Why 50 years? 50 years ago, I arrived in 1974 in Phoenix. Just so you understand where we were. 1974, there was not a CT scanner in the state of Arizona. There was only one MS specialist in the state of Arizona, and that was Dr. Bill Sibley at the University of Arizona in Tucson. None in Phoenix. There were, obviously, if there wasn't a CT, there wasn't an MRI. There were no disease-modifying therapies. Those didn't arrive on the scene until 1993. So really 20 years after my arrival. That meant that we often, the neurologists were often accused of being specialists who phrased, I diagnose an adios. Here the adios was really in a literal sense, diagnose an adios, to, you're in God's hands, adios, to God. So we've done what we could do, nothing more. It's very different now. I've talked about the fact that we're making our diagnoses earlier and earlier based on revised McDonald criteria. That was presented in Copenhagen a couple of months ago. This uses both spinal fluid. You know about oligoclonal bands. They're now being able to use kappa light chains as well in spinal fluid to make to confirm diagnosis. We're using MRI in a much more sophisticated way, not just looking for old and new lesions, gadolinium lesions and T1 non-enhancing lesions, or T2 non-enhancing lesions, but we're also looking at things like central venous signs, which are specific to MS and not to the non-specific white matter changes that radiologists sometimes confuse with demyelination. We're also looking at paramagnetic rims, kind of an iron deposit along the edge of chronically active MS lesions. Using these increased skills in MRI observation, using increased definitions based on relapse, we're really trying to diagnose earlier and successfully have done so. In terms of following MS, we're at the threshold of being able to use humoral biomarkers. Once upon a time, we really couldn't do that. Neurofilament light is released, as you all may know, from the axon, part of the exoskeleton. It's a protein that is released into the CSF, but it's also released in tiny particles from the from the CSF into the bloodstream. We've now got this technology to be able to measure that in the bloodstream. And as such, we can get some sense of inflammation and can use neurofilament light, not for diagnosis, but rather for understanding of degree of inflammation, likelihood of relapse. GFAP, another biomarker from the astrocytes, and we're able to use that as a better understanding of progressive MS and probably a better understanding of prognosis of progression. So we're better and better right now than we were. Next. So again, where are we? Where have we been? 1993, the first disease-modifying therapy. The early disease-modifying therapies, which were copolymers and interferons, were really a godsend. We were thrilled to have them, but we understood that they had limited power. They were 30% better than placebo. Now we have over 25 disease-modifying therapies that are approved, and we've evolved from those early safe but relatively ineffective legacy meds, the injectables, to oral agents that were generally about 50% better than placebo, but with more immunosuppression and more side effects, to really more highly effective medications. And those are really the monoclonal antibodies, the B-cell depleters, and others. So I would say we classify probably 5 as being highly effective. Those include cladribine or Mavenclad, 3 B-cell depleters, anti-SABRI. The philosophical shift has been toward the use of highly effective agents earlier. So 30 years ago, the relapse rate in the pivotal trials was approximately 0.63. That meant one relapse every year or two. In the most recent trials, it's 0.1, a relapse every 10 years. There's a study out of Vienna just published last week that said in highly effective therapies, when used at the very onset of disease, with young new patients not waiting till they failed other medications, that the number is even better than that 0.1, approaching 0.02. So we're getting better and better and better at reducing the acute inflammatory aspects of MS, the relapses. As a clinician, I will tell you that I get MRIs still on my younger patients, particularly once a year. And when I do those, it used to be 30 years ago, I would see new lesions on patients all the time, every week, often every day. Now it is uncommon for me to see a new enhancing lesion in a patient on highly effective therapy. Next. Philosophy. Next. So this is a discussion about how we approach. So I've given the first idea about philosophy, and that is early use of high efficacy therapies. Previously in the US, there was a tendency to escalate, starting with lower efficacy agents and escalating when those agents failed to higher efficacy agents. I would say the most important trend in the world and in the US right now is the initiation at the onset of higher efficacy agents, not requiring the failure of lesser efficacy agents. In so doing, we really replicate the early trials of the highly effective agents, which showed that if you began with a highly effective agent compared to their active comparator, that the group that was on the less effective agents would develop disability during the 2 years of the pivotal trial, which they never made up even when they were switched over to the highly effective agent. So philosophically, we and I, we, the MS community, I individually really endorse in most patients, starting with a highly efficacious agent earlier and less likely to use the legacy meds. And then what about shared decision-making? I think we all pay lip service to shared decision-making. I don't think it's 50-50. I think the percentages shift back and forth. I have patients who tell me what they will and won't do, and they've already made up their mind, and there isn't as much decision-making. I have other patients who rely heavily on the advice we give, but it really needs to be mutual. And I tend to say, let's talk about these agents. Let's talk about the ones that I generally prefer, especially, but let's talk about all of them, but with an emphasis on the more effective agents. And then how does that fit you? Some people want a pill. Some people want an injection. Some people want an infusion. But in all of those instances, we can choose highly effective agents, and that's really one of the nice things. If we do get shared decision-making, side effects are less, they're better tolerated when they occur, adherence is better, and if adherence is better, outcomes are better. So I think it's more likely they'll stay on the medicine that they collaborate in choosing. I think it's more likely they'll adhere to the medicine with better outcomes. And so shared decision-making is very much part of the formula. Next. So some things that are easy and some that aren't. Some things we really know, some things we don't. So when to start treatment? I think we have an answer to that. 30 years ago, there was a debate about when to start the disease-modifying therapy. Should we start immediately or should we wait? The Mayo Clinic at that time was the most conservative and said, let's wait. The rest of the community, I think, was more correct. That is, initiate really upon diagnosis, unless there's some reason you can't. And so really the when to start is start really as soon as you can. And that means starting an agent as soon as you can and trying to work to make sure that patient can get that agent. The stroke neurologist coined the phrase time of brain. The MS neurologist grabbed that idea. We say, if we've got a great agent, we want it to work quickly, but we want to be able to get it into the hands of our patient early too. So delays in making the diagnosis make it harder. Delays in getting that confirmed make it harder. We really try to start right away, as in most situations, and we think that makes a substantial difference in outcome. When to switch? I think that's also relatively easy. If the patient is breaking through clinically, after the medicine has had time to be fully up and running, we think our medicines need 3 to 6 months to be fully up and running. If by 3 to 6 months they're still showing new, they're still having new relapses, it's not that the medicine has failed, but it's probably suboptimal. If they have new gadolinium-enhancing lesions on their MRI, it doesn't mean the medicine has failed, but it does mean to me that the medicine is suboptimal. So if I get a relapse in the first week or month or 2 or 3, that could be just the lag in onset of the medication. But if I'm getting breakthroughs at 6 months radiologically or clinically, it means my medication is suboptimal and I'll change. If they have side effects they can't tolerate and stop the medicine, I'll switch. If they have medications that they can't tolerate and are still taking it, but it's ruining their quality of life, I'll switch medication. And if they have other hazards, liver, hematologic, etc., that require me to change, I'll change. So those are the easy ones. When to stop is not easy. We know that the acute inflammatory phase of MS, the RAW that I talked about, the relapse-associated worsening, the new gadolinium-enhancing lesions on MRI, the new acute attacks, tend to diminish as you age. We think that age for the population begins in one's 50s and continues through one's 60s. And so we particularly evaluate the risk-benefit ratio of the agents we're using as our patients age, saying, is it still worth it? I just had a patient this morning. I was doing the MS clinic at Banner University, and one of my patients who is 37 years old said, I'd like to stop. And my answer was, again, we're going to have shared decision-making, but I want you to stay on medications. Ask me that question again in 20 years, and we'll have a sort of a different. I said, by the way, it's your choice. You're the boss, but here are the reasons I want you to stay on medications, and that is, an acute attack might be disabling. So we had a study called the DISCO MS study that confirmed that people in their 50s and 60s are less likely to have a relapse on and off medication. I think this is the time for shared decision making. I have 60-year-olds who say, and I have 65 and 70-year-olds who say, I'm on a relatively safe medication. I want to stay on it. I just have peace of mind, and there are no hazards that I can see. I say, great. I have 55-year-olds who say, I'd like to see how we do off medications. If the MRI has been stable and they've been stable for a while, I say, okay. Because this is an area we still don't fully understand and for which we don't fully have biomarker and MRI collaborative data, I really do believe we have to bring the patient in to the decision making. Here especially, the other places also, of course, here especially. Next. So, disease modifying therapies. I talked about MSAA. MSAA has a what's called the ultimate treatment guide for MS. They have every agent, and they have every agent with writing about every agent. And so every agent and its sort of use, its indications and contraindications are listed. But each one of the agents has a neurologist from across the country, 25 different neurologists who will speak to that agent and try to make some sense of it as a clinician to clinician, or clinician to family, or clinician to patient. So consider the MSAA Ultimate Guide to MS Treatment. I think it's a useful tool. Mostly, I will tell you that Again, my view is that I like the use of highly efficacious agents. And if someone says to me, I gave grand rounds at the University of Arizona Friday, and the ex-chairman, David Labiner, said, don't you think you're over-treating some people who are going to do well otherwise? And my answer was yes. I know that there are 5% of people who, even on no therapy, will do well. But I don't know who they are, and the old demographics that I use to try to judge prognosis were great for population, but not at all adequate for the N of one, the individual patient in front of me. So I very much say I overtreat the few to protect the many. I like my more effective agents. But you're always going to take into account what is their age, what is their comorbidities, what's their preference, what are they willing to do? Do they want to get pregnant? Do they have cancer? Et cetera. There's so many things to take into account. Next. So in addition to disease-modifying therapies, there have been relapse therapies since I was a medical student, mostly steroids, sometimes ACTH. But we say about these, they're good for shortening the duration of the relapse. They don't tend to make a big difference in outcome. So if you're going to get 90% better after relapse, you'll still get about 90% better after steroids or ACTH. On the other hand, if you have a terrible symptom, it will shorten the duration in which that symptom is bad. For very severe episodes, we'll also consider PLEX, plasma exchange. Next. And symptomatic therapy. So when we start a patient on a disease-modifying therapy, we're really saying, you'll thank us in 20 years because the likelihood is that you're going to do far better than you would have done. When I was a young neurologist and there were no disease-modifying therapies, too many patients had too much progression, including too many wheelchairs. Today, that's quite uncommon. We have much more commonly patients who are doing quite well with MS. And so we're saying, you'll thank us in 20 years. But that doesn't affect their day-to-day living. And so the question is, what about how I feel right now? And that's where symptomatic therapies come in. We're better at that than we used to be. We always had some ability to do that, but we're better. So is that a matter of their gait? We have medications now, dalfampridine, that improve gait in many of our patients with MS. But we also have physical therapy, occupational therapy. We have the ability to treat pain. I will tell you that I have not found injectable therapies as useful in treating pain management of MS because the nidus of the pain is not some peripheral structure, but rather the central nervous system. But I think pain management can be very helpful. I think physiatry, physical medicine rehabilitation, and OT-PT speech can be very helpful. People may complain of cognitive impairments. It's usually processing speed, but we can have them tested, neuropsychometric testing, and we can get them speech therapy to work on strategies for their cognitive complaints. And for some people, it's not as important as others, but for many people, it's the difference in staying on their job. It's the difference in their social relationships, et cetera, et cetera. It's important. Fatigue is the most common symptom in MS, but we can do a lot about fatigue. Again, wellness, exercise, healthy diet. We have medications for fatigue in MS, but we concentrate on all of it. We should never forget that fatigue is not, even if it occurs in a person with MS, is not always a primary symptom of MS. It could be secondary to depression, secondary to getting up 3 times in the middle of the night to pee because of a bladder problem, secondary to the medications we're prescribing for them, et cetera, et cetera, et cetera. So there can be many reasons. Mental health. I have my middle daughter is a neurologist. My oldest daughter is a psychologist. My younger daughter is a psychiatrist. And so I'm fairly sensitive to mental health issues. Depression and anxiety are far more common in MS than in the general population. We believe it's a biologic, not a sense of sadness about the diagnosis, although both can occur. We believe that brain disease is associated with an increased incidence of depression and anxiety. And so we believe that it's important to have mental health correlate, collaborative, takes a village. And we think that becomes very important. Again, vision can be part of it. What I'm telling you in its entirety is there's so many things that affect quality of life, whether it's bladder or processing speed or pain or fatigue or gait or balance. All of those things can be dealt with both medication, wellness protocols, and the appropriate specialties. It's a collaborative. Next. So I'm not sure if this is complementary therapy or wellness or brain health, but really, every day for virtually every patient, my discussion is about wellness, and that is, are you eating healthy? We concentrate less today on weight itself and more on healthy eating, though both affect prognosis in MS. Weight affects the long-term prognosis if there's obesity. Fatigue and sense of well-being improve with better nutrition. We currently like the Mediterranean diet because it's not impossible to do, but there are many diets that are touted. We believe in exercise, regular physical activity. We tell people not to go out and run a marathon unless they're capable, but rather to do steady, regular exercise. We want to make sure they maintain their brain health by continued engagement of their intellectual function. And we try to make sure that they maintain their social connections. It's so easy to become isolated with chronic disease, and we push very hard against that. Whether that means friends or family or faith, how you get there is how you get there, but we stress it. And then at the very top, it says multidisciplinary care, collaboration among healthcare physicians or professionals. That means nurse practitioners and PAs and primary care. That means OBGYN, neurology, physiatry, psychiatry. You all may know, but I'll take this moment to tell you that we understand that it takes a village. And next slide. Oops, next slide. Let's go back one, I'm sorry. We know it really takes a village. You can't do this and get the same outcomes as a neurologist just managing medications. We know that progression, disability are heavily dependent on comorbidities. So if I'm doing my job great, but their diabetes is out of control, their hypertension is out of control, their pulmonary status is out of control, their renal function is out of control, they're going to progress at a rate far more rapidly than would be the case otherwise. That means if I'm doing my job great with disease-modifying therapy only, I'm not doing my job. I need to be sure that the comorbidities are also being looked at, which means that your role in the care of MS patients is enormously important, not just because of the need to treat that isolated comorbidity, but because it affects the long-term prognosis of MS. We need you, you need us. Our patients need both of us. It takes a village. Next. So where are we going? I told you that we were really good at reducing acute relapses, and we are. We have not been very good at reducing long-term progression. There is a new molecule you'll be hearing about more called BTKI, Bruton's tyrosine kinase inhibitors. They have some advantages over our current therapies. Our current therapies are large molecules that treat MS in the bloodstream. By and large, they're not brain penetrant. If there is, and we believe there is, a smoldering inflammation that goes on sequestered in the brains of patients with MS, you can't get to it with our current agents, which means that the progression of MS is kind of untouchable once it's reached a certain stage. BTKIs are small molecules, brain penetrant, can get to the source of smoldering inflammation, and have the advantage, as opposed to our current medications, which concentrate on the adaptive immune system, on working on the adaptive and innate immune system. We think that the smoldering inflammation depends on B cells, the adaptive immune system, and activated microglia, the innate immune system. We think that if you're only doing one side of the immune system, you're missing half. And so we're thrilled that what we believe will be the emergence of a new therapeutic class in the coming year. We had a successful trial I keep on talking about a few months ago in Copenhagen at our big international meeting, ECTRIMS. We had a successful trial, first successful trial of the BTKI in significantly reducing progression in people who are progressing without relapses. So this is a one to keep your eye on. Next. I told you keep your eye on the EB virus. We were recently asked if we would participate in the EB virus vaccination trial. The problem is that one would have to vaccinate early in the disease from my perspective, although this vaccination trial will attempt to do so later. But it appears very strongly that EB virus is a central provocative tool. Whether it perpetuates the disease or not, we'll find out. But watch attention to be given there. Next. I've been part of two remyelination projects, research projects, both failed. 15 years ago, I said, I guess 10 years ago, I used to say, I think it's 5 years away. Today, I think it's 10 years away. Sooner or later, we'll learn to repair the nervous system, but it is a far goal rather than a close goal. Next. Final tips, final takeaways. Early diagnosis and intervention are key. I believe in the early use of higher efficacy agents rather than the escalation approach. We need to do shared decision making. We need to be willing to change when things aren't going well. We need to understand we're part of a team and part of a village. We can't do it alone. And we need to really consider not just all of us in this together, but the patient's role in terms of wellness. I used to want to begin every discussion and end with every discussion with Bob Dylan's The Times They Are Changing. MS is certainly changing. And Bob Marley, everything's going to be all right. There is hope on the horizon. And I've tried to give you a bit of how much we've accomplished so far, but why I am so hopeful for the future. I'm delighted to pause now. I think we've got maybe another 15 minutes for any questions that any of you might have.
Oh, thank you, Dr. Hendin. What a wonderful presentation and information you shared with us today. We do have some time for Q&A, and with that, I'm delighted to introduce Dr. Sherry Brown, who will be joining us for our discussion. Dr. Sherry Brown is a Senior Medical Director with Blue Cross Blue Shield of Arizona, who supports the development of policies and programs to best drive enhanced health outcomes, including our health management program, supporting individuals with individualized care, outreach and support with chronic conditions, as well as our clinical rapid response team supporting individuals when they need it most in a timely manner. I'll just kick it off with one first question around so much that you spoke to around the evolution and changes. But fast forwarding to today, what does the disease burden look like in terms of trends in the state or in the country in terms of individuals and community impacted by MS?
So you'd hope that our successes in therapy have translated out to successes in outcomes. And that may be the question you're asking. And the answer is absolutely. So I don't know if it's easily understood, but there has been what we say as a 7 to 10 year earlier mortality in the patient population with MS by early studies 30 years ago. So the early studies said people with MS die 7 to 10 years earlier than the general population, usually concentrated in the people who are having the most problems. Those numbers are getting better and better and better. And I really can say to my patients with MS, and now with the early use of high efficacy therapies, our goal is to keep you like you are. And it means I can't promise that they will never have a relapse. I can't promise that they will not progress at any point as they age, but the likelihood is that I can keep them highly productive during their adult years, and that and have them maintain a normal lifespan, and with MS as an annoyance, but not as the crucial aspect in their health. That wasn't true. Again, I've been a neurologist for 50 years. I could never have said that 50 years ago, or 40 years ago, or 30 years ago, or 20 years ago. Our more effective agents have allowed us to say to patients, our goal is to keep you the way you are. And I would say, if it's the trends in treatment around the valley, around the country, it is an adaptation. We know the trend is for the earlier use of higher efficacy therapies as a trend around the nation. I believe that has been a big part of it. I believe wellness has been a very big part of it. Just the fact that we are concentrating on something we should have been concentrating on 50 years ago. Are you exercising regularly? Are you eating healthy? Are you maintaining your mental health? Are you seeing your primary care doc and making sure your comorbidities are being managed appropriately? All of this is helping. And to the extent you'd say, I think some of it has also been MS centers. So we're an MS center. The Barrows is an MS center. Honor Health has an MS center. Mayo has an MS center. I think the care delivered in centers is excellent, but you know, Carla in particular, that we have wonderful MS-focused clinicians around town, and they're part of I didn't mention Banner. I should have, because I'm a Banner. But we also have individual MS-focused clinicians. MS-focused clinicians in and out of centers tend to make a big difference.
Thank you, Dr. Hendin. I have a question for you in relation to symptoms. You mentioned a variety of symptoms. Can you highlight the most common ones versus the invisible kind of symptoms? And how early on with subtle symptoms should you do diagnostic testing?
Dr. Brown, you just froze. I got the last part of the question, but I didn't get the first. Could you repeat that for me?
Absolutely. So you mentioned a variety of symptoms, some that are common versus some that are a little bit less common or invisible. Can you highlight some of those symptoms, and how subtle of a symptom would you act on a diagnostic test for?
Sure. Let me say, as you imply, there's some symptoms that are highly specific. In a young, not 100% specific, but if I see a 25-year-old with acute onset of optic neuritis, my first thought is that this is either going to be MS or neuromyelitis optica or MOGAD. So something that is an immunologically based one. I certainly won't in an 80-year-old man in whom I'm going to think the etiology is different than ischemic optic neuritis, for example. So in the appropriate population, the first three to think about are optic neuritis, partial transverse myelitis, which is numbness from tummy on down, chest on down, neck into the right arm, with Lhermitte's phenomenon. When you bend your neck, you get a zing into your hand, and then what we call brainstem cerebellar in coordination with double vision. Those are the three classical, non-specific presenting signs. Not always MS, but you always ought to ask that question. So you get optic neuritis, partial transverse myelitis, brainstem cerebellar, always think about it. The others are harder, so it's really listening. So if a person says, I'm having fatigue, and then you say, I'm going to do an MRI for MS on every fatigue, you'd be doing a lot of unnecessary MRIs. So the question is, does it sound like it is explained by something else? If it's explained by something else, it's something else. And then you do the exam. And I always say the history sets up hypothesis. When you listen to the history, you say, I think this is what it sounds like, or these are the things that sound like. The exam is test of hypothesis. Never underestimate the importance of a good history and then a confirmatory exam. If you've got a non-specific history and the toe goes up, work it up for a neurological disorder, including MS. If you see that there's an acute loss of vision one eye, or that there is an extraocular motor deficit or cerebellar problem, even if the symptoms were non-specific, the exam should put you that way. So now I'm going to answer it. I hope to answer it now more in a more succinct way. There are nonspecific symptoms and specific symptoms. The specific symptoms you chase, optic neuritis, partial transverse myelitis, brainstem cerebellar. The nonspecific symptoms could be anything, and what will push you over the edge is a red flag. A red flag could be something you find on the exam or something that sounds wrong. They're fine, but they've got Lermite's phenomenon. They flex their neck and they get a zing down their spine. You have them try to hold their balance and they can't hold their balance. They tell you that their balance is off. That's not okay. And so I'd look for a red flag. Fatigue, nonspecific. Diffuse aching, nonspecific. Memory changes, nonspecific. But with the red flag, investigate.
Thank you, Dr. Hendin. I'm going to take one of the questions from our audience that's identified, and I know you spoke to comorbidities, and that can occur, and the importance of care there, especially the multidisciplinary care. So an individual asked specifically around MS and myasthenia gravis about organizations and specialists out there, or kind of broader to comorbidities, and then the question here specific to myasthenia gravis.
Sure. So the first thing I have to tell you is that sadly, my expertise actually is in MS and NMO and MOGAD. I don't have the same level of expertise in the neuromuscular junction myasthenia, but I was once a proper general neurologist, and I know myasthenia. So I will tell you, in terms of a comorbidity, I've only seen myasthenia plus MS once. You're going to be told that myasthenia is often associated with autoimmune diseases. It's occasionally associated with other autoimmune diseases. Neuromyelitis optica is often associated with other diseases. It's an autoimmune disease. We know the antibody, we know the antigen, it's autoimmune, and we have other comorbidities, including myasthenia. There is a myasthenia foundation, and there are excellent places for myasthenia in this town. I won't name them all, but again, Banner Health, Honor Health, Barrows, Mayo Clinic, excellent for myasthenia.
Thank you, Dr. Hendon. I have a question for you as well regarding that multidisciplinary approach. Is there certain specialists or healthcare professionals that you would recommend always gets involved in the care for someone with MS? And if you can highlight maybe some of the not so common professionals that you would recommend get involved.
So I will tell you that the ones that the one that I always want to have involved is primary care. And sometimes patients with MS think that the neurologist is their primary care doctor, and they're wrong, because we are not very, we're at the very best, we're mediocre. And so I always want a really good primary care doctor on board. That's number one. Number two, urologic symptoms are so very common in my patients, and I ask to sensitize it. So I don't say, are you having problems with bladder, in which case I'll often say no. I say, are you feeling urgent? Are you having frequency? And then I ask, are you always getting to the bathroom on time? And they'll say, well, not always. I say, urology. I have a low threshold for referral, for either treating depression, if it's very easy, or referring to psychology and psychiatry. That is a very much of a go-to. I think physiatry can be very helpful when there are functional difficulties, and then OT, PT, speech. And those are the ones that are my most frequent go-tos. The other one is pain management. When I was a young neurologist, we were told that pain was not part of MS. That's nonsense. Pain is part of virtually everything I take care of, and a really good, conservative, thoughtful pain management doctor is a real assist. I always want to let my patients know there is secondary MS pain and primary MS pain. Primary MS pain is things like trigeminal neuralgia and the itching you might get in your arm, Lermite's phenomenon. You don't inject that. The secondary ones that are due to structural changes may take a different approach, but I need a pain management doctor who is holistic and does things other than just inject.
Well, Thank you, Dr. Hendin. Well, we're coming up on time, and I know many of us would love to have more hours of time with you to hear all about your expertise and your wisdom. But I did want to just thank you for taking the time, taking the hour to present to us today, to talk about the evolution and ending on hope through the change is such a great component there. I would also like to thank Dr. Brown for joining us in the discussion today. And if we could just bring up the final slide, I do want to make sure I provide information around folks who are receiving or who would like to receive continuing education credits, as well as those who are not and would like to provide feedback on the session today. It could help us inform future sessions for 25 and into 26 for the Arizona Community Grand Rounds. Complete the survey. And that will give you the information for that. Please also keep an eye out for a post-session email where we will provide today's recording. Attendance at the live session is required for the CEs, but anybody can listen in at any time to the recorded session. And just so very much thank you for joining us in this time today. We hope to have you join us in the future sessions that we have in 2025. And again, thank you. Look forward to seeing you soon.
Carla, and Dr. Brown, as always, and Jennifer, I'll thank you very much. It's truly a pleasure for me. This is a subject about which I care deeply, and giving us a forum to talk about it together is part of what you always do, and always do so well, and thank you.
Thank you.
Appreciate it. Take care, everyone.
Bye-bye all.